Have you ever heard someone mention high blood pressure and thought, yeah, that sounds bad, but how bad can it really get? Well, what if that blood pressure is so incredibly high it becomes like an immediate life-threatening emergency? And then what if there's a completely different kind of high blood pressure, one that hits a very specific part of your body and often just flies under the radar until it's really serious? Welcome to the deep dive. This is where we take complex topics, dig into the sources, and give you the shortcut to being, well, genuinely well informed. Today, we're diving headfirst into two distinct but equally critical forms of elevated blood pressure: hypertensive emergency and pulmonary hypertension. We've sifted through comprehensive medical texts and clinical guidelines to pull out the essential knowledge for you. Our mission is pretty straightforward: clearly define these conditions, explain their unique dangers, and show how doctors diagnose and manage them with actually surprising precision. First up, we'll dissect hypertensive emergency. That's when your systemic blood pressure, the one measured on your arm, is dangerously high and actively damaging your organs. Then we'll pivot. We'll look at pulmonary hypertension, a condition of high pressure, specifically in the lung arteries, which puts a unique strain on the right side of the heart. Get ready for some really crucial distinctions and some fascinating medical insights. Okay, let's unpack this first one. When we talk about a hypertensive emergency, it just sounds terrifying. But simply having really high numbers isn't the full story, is it? What truly defines this urgent medical situation? What's the real difference between an emergency and something, less critical?
That's a really key distinction to make. A hypertensive emergency isn't just about the numbers, although, yeah, they are certainly extreme. We're talking about a systolic pressure, that top number, usually way over an 80, or a diastolic, the bottom number, over 120. But the key difference, the thing that makes it an emergency, is that this severe high pressure is actively causing new or worsening damage to vital organs. Right now, if someone has those same crazy high numbers, but crucially no signs of organ damage, we call that hypertensive urgency. Still needs attention, absolutely. But it's not that immediate life-threatening crisis. It's the presence of organ damage that really rings the alarm bells and demands immediate action.
Okay, so active, ongoing damage. What kind of damage are we actually talking about here? Can you give us some examples that really highlight how critical this is for the listener? What signs is a doctor looking for?
Well, we're looking at acute problems, basically failures, in vital systems all through the body. For instance, neurologically, you might see severe headaches, really blurred vision, seizures, or even sudden confusion or change in mental alertness. For the heart and lungs, it could show up as sharp chest pain, struggling to breathe, shortness of breath, or fluid backing up into the lungs, what we call pulmonary edema. The kidneys might start shutting down, so you'd see a sudden drop in urine output. And beyond those, it can also trigger incredibly dangerous situations like an acute aortic dissection. That's a tear in the body's main artery, the aorta. Or eclampsia in pregnancy, which is life-threatening for both mother and baby. Or even an acute stroke. It's serious stuff.
And what usually causes such a sudden, dangerous spike in blood pressure? What leads to this kind of emergency?
Often, the most common reasons are either completely undiagnosed, high blood pressure someone didn't know they had, or what's called essential hypertension, the most common type that just hasn't been managed well enough. The treatment isn't working, or maybe they stopped taking it. But there are also more specific underlying causes, too. Things like kidney disease can trigger it. Certain endocrine disorders, like pheochromocytoma, that's a rare tumor that makes your adrenal glands pump out way too many stress hormones like adrenaline. Or, as we mentioned, pregnancy-related conditions like preeclampsia can also lead to it.
Wow. Okay, so given the potential for such widespread and immediate damage, how do medical teams quickly evaluate someone they suspect might be in a hypertensive emergency? It sounds like there's absolutely no time to waste.
You're spot on. Time is absolutely critical. The approach has to be rapid, but still really thorough. A key question they're asking is, what are the quick clinical clues, the fast tests we can rely on right now? Medical teams focus mainly on the neurological system, the cardiovascular system, and the renal system, brain, heart, kidneys. During the physical exam, they'll always check blood pressure in both arms, and then repeat it after maybe 5 minutes just to confirm. And here's a really striking detail. If there's a difference of more than 20 millimeters of mercury between the arms, that could strongly suggest an aortic dissection, that tear we talked about. It's a big red flag.
Huh. Both arms. That's interesting.
Yeah. They'll also do a fundoscopic exam looking into the back of the eyes with a special light. They're checking for specific changes like tiny bleeds called retinal hemorrhages or swelling around the optic nerve called papilloedema. These are signs of pressure damage. And a quick bedside neurological check is essential too, just to assess brain function quickly.
And what about initial lab tests or imaging? Do they wait for results or do they start treatment first?
Generally, they try to get baseline blood and urine samples collected before treatment starts, if possible. Specific tests get ordered based on suspicion. So maybe cardiac enzymes if they think the heart's involved, or a urine drug screen if the illicit drug use seems possible, maybe specific hormone tests if they suspect something like that pheochromocytoma. Imaging is also really key. Urgent CT scans of the head or chest are often done right away if they suspect a stroke or an aortic dissection. It's all about gathering enough critical information to act fast.
Okay, this is where it gets really interesting for me. The sources emphasize that treatment for a hypertensive emergency should not be held up while doing the full diagnostic workup.
Yeah.
It sounds like your real balancing act, you know? Speed versus precision, like high-stakes detective work.
It absolutely is a real balancing act. The immediate goal, the first step, is to reduce the mean arterial pressure, that's kind of the average pressure in the arteries, but by no more than 25% within the first hour, maybe even faster in some cases. And this is a really critical warning, something important for you to understand. Dropping the pressure too much or too fast can actually be dangerous. It can cause ischemia that's reduced blood flow and oxygen to vital organs like the kidneys, the brain, or the heart. You risk damaging the very organs you're trying to protect.
Right, so you could fix the pressure but cause a stroke or kidney failure.
Exactly. So it's a very careful, controlled reduction. If the patient is stable after that initial drop, then further gradual reductions happen over the next, say, 2 to 48 hours. And what's really fascinating here is that the choice of medication isn't just random, like picking one off a shelf. It's very specifically dictated by which organ system is being damaged and the patient's overall condition. It's truly precision medicine, but happening in an emergency setting.
That makes total sense. Can you give us a couple of really vivid examples of how that treatment gets tailored for these really specific high-stakes situations?
Absolutely. Let's take that acute aortic dissection again, the tear in the main artery. In that case, the blood pressure needs to come down quite aggressively. The typical goal is getting the systolic BP, the top number, below 120 and doing it within about 20 minutes. But here's a crucial point of precision. You must give beta blockers first. Those are drugs that slow the heart rate and reduce how forcefully it pumps. Only after the beta blocker is working should you give vasodilators, the drugs that relax the blood vessels.
Why that order?
Because if you give the vasodilator first, the heart might reflexively start beating faster and harder to compensate for the drop in pressure, and that extra force could actually make the tear worse. So beta blocker first, then vasodilator.
Wow, okay. That's specific.
Very specific. Another really interesting one is hyperadrenergic states, situations where the body is flooded with adrenaline-like substances. Think cocaine toxicity or that pheochromocytoma tumor. For cocaine use, often the first-line treatment is actually benzodiazepines like Valium. They help calm breathing down. But for pheochromocytoma, the approach is very different and kind of counterintuitive. You need an alpha blocker first, something like phentolamine. This blocks some of the effects of the excess adrenaline. Critically, you must give this before you even think about adding a beta blocker. Why? Because if you give a beta blocker alone in this situation,
Let me guess. It makes things worse.
spot on, it can block the body's ability to relax blood vessels, leading to something called unopposed alpha-adrenergic vasoconstriction. Basically, the blood vessels clamp down hard, and the blood pressure can shoot up to even more dangerous, uncontrollable levels. So alpha blocker first is crucial.
That's fascinating. Almost the opposite of the dissection treatment order.
Exactly. And one more quick example. Severe hypertension in pregnancy, like preeclampsia or eclampsia. Here, there's a very specific target BP range. Doctors aim for a systolic between 140 and 150, and a diastolic between 90 and 100. Not too high, not too low. This is often treated with IV meds like hydralazine or labetalol. And they often use magnesium sulfate too, but it's important to know that's primarily to prevent or treat seizures, not really for the blood pressure itself. These examples really show how incredibly specific and vital each treatment choice is.
Wow, that level of precision under pressure is just incredible. Okay, so we've unpacked the intense urgency and the really tailored treatment of hypertensive emergencies. But you mentioned another complex, maybe less commonly understood type of high blood pressure, pulmonary hypertension. How is this different from the systemic kind we just talked about, the one measured in your arm?
Right? Pulmonary hypertension, or PH, is fundamentally different. It's all about elevated pressure, specifically within the pulmonary vascular system. That's the network of arteries carrying blood from the heart to the lungs. When these lung arteries become narrowed or stiffened, the right side of your heart has to work much, much harder. to push blood through them to pick up oxygen. The diagnostic threshold is usually defined as a mean pulmonary artery pressure, and average pressure in those lung arteries greater than 25 mmHg when the person is resting. So the key takeaway here, the big difference, is that while both conditions involve high pressure, pH is pressure in the lungs' arteries.
Yeah.
And that directly strains the right side of the heart, specifically. This leads to a whole different set of challenges and symptoms compared to systemic hypertension, which affects the whole body via the left side of the heart.
Okay, so it's targeting a different part of the system. And what's the long-term effect of that specific strain on the right side of the heart? It sounds like it could create a dangerous cycle.
It definitely can become what some call a slippery slope. Over time, that prolonged pulmonary hypertension makes the right ventricle, that's the heart chamber, pumping blood to the lungs works so hard that the muscle wall thickens. That's called hypertrophy. But eventually, it can get tired and stretch out or dilate. When that happens, it can lead to problems like the tricuspid valve leaking, that's called tricuspid regurgitation, allowing blood to flow backward. This strain on the right side can eventually start affecting the left ventricle too, and ultimately it can lead to right heart failure and even complete cardiovascular collapse if it's not managed.
Gosh, that sounds like something that might be really hard to spot early on, especially if, as you say, the symptoms are different. What are the common symptoms and how do doctors usually diagnose it?
You're absolutely right. The symptoms are often frustratingly nonspecific, which makes early diagnosis tough. The most common ones are progressive dyspnea, that's shortness of breath that gradually gets worse over time, and fatigue, just feeling really tired. Because these symptoms are so general, lots of things can cause shortness of breath or fatigue.
Yeah, could be anything.
Exactly. So it makes diagnosis challenging. That's why clinicians really need to maintain a high index of suspicion for pH. They need to actively consider it in patients who come in with unexplained shortness of breath, especially if other common heart or lung conditions have already been ruled out. They have to think, could this be pH? Now, while tests like an ECG, the heart tracing, or a chest x-ray might show some abnormalities suggesting heart strain, they're often not sensitive enough to definitively rule pH in or out early on. The best initial screening test mentioned in our sources is Doppler echocardiography. That's an ultrasound of the heart. It uses sound waves to create moving pictures of the heart and estimate blood flow and pressures within the heart chambers and pulmonary arteries. It gives a good initial idea if pH might be present.
Okay, so echo is key for screening. Once pH is suspected or maybe confirmed, how is it managed, particularly if someone shows up in the ER really struggling? How do doctors support that overworked right side of the heart?
In an emergency setting, the immediate care really focuses on supporting the patient's basic functions. First, maintaining oxygen levels, keeping oxygen saturation above 90%. That's critical. Second is carefully managing the body's fluid balance. If there's fluid overload, diuretics water pills can be used. But, and this is important, they have to be used cautiously. Removing fluid too quickly or too much can actually cause systemic hypotension, dangerously low blood pressure throughout the body, because the struggling right heart needs enough fluid volume to function properly. It's a very delicate balance.
It's another balancing act.
Definitely. And for direct heart support, medications like dobutamine or milrinone might be used. These are drugs called inotropes, and they help strengthen the heart's pumping contraction, specifically trying to boost that struggling right ventricle. Now, this actually brings up a really important point, a critical pitfall that highlights the huge difference in managing pH versus, say, a heart attack. Why might a common medication given for chest pain, like nitroglycerin, actually be dangerous for a patient whose problem is pulmonary hypertension causing right heart failure?
Oh, that's interesting. Why is that? Nitroglycerin relaxes blood vessels, right? Wouldn't that help?
You'd think so because it does relax blood vessels and is great for coronary artery disease causing a heart attack.
Right.
But in a patient with severe pH and right heart failure, their overall blood pressure might already be quite dependent on having enough fluid volume getting back to the heart. Giving sublingual glycerol trinitrate, or GTN, that little tablet under the tongue, can relax the veins throughout the body so much that it drastically reduces the amount of blood returning to the heart. In someone with a failing right ventricle, this sudden drop in preload, the filling pressure, can cause a catastrophic drop in overall blood pressure, leading to collapse.
Yeah.
So it's specifically contraindicated, a big do not give, a critical difference.
That is a massive distinction. And yeah, potentially life-saving knowledge for a medic.
Yeah.
So what happens after the immediate crisis? I'm guessing managing pH is a long-term thing, not a quick fix.
You're absolutely right. Pulmonary hypertension management almost always requires specialized care, usually at dedicated pH centers. It involves long-term strategies. This often includes combination drug therapies. There are several different pathways involved in causing the lung arteries to narrow, so using multiple drugs that target different pathways often works best. It's like attacking the problem from different angles. And in some severe or advanced cases, more invasive treatments might be needed. Things like an atrial septostomy, creating a small hole between the heart's top two chambers to act like a pressure relief valve for the right side. Or ultimately, even lung transplantation might be considered for eligible patients. So if you zoom out and look at the big picture, pulmonary hypertension really highlights the need for highly specialized, incredibly nuanced care that goes way beyond just standard blood pressure management.
Yeah.
Okay, so we've really taken a deep dive today into two very distinct but equally serious forms of high blood pressure. Just to recap, remember, a hypertensive emergency is about that systemic blood pressure, the pressure everywhere, being so high, it's actively damaging organs right now. The key is immediate but careful blood pressure reduction to protect those organs. Meanwhile, pulmonary hypertension is totally different. It's high pressure specifically in the lung arteries, putting a unique and dangerous strain on the right side of the heart. Its management requires different strategies, often highly specialized, focused on supporting that right ventricle and treating the underlying lung vessel disease. Both need rapid diagnosis and tailored treatment, but the why and the how are fundamentally different.
Exactly. And understanding these differences, I think, really reveals the incredible complexity of our circulatory system. It also highlights the amazing level of precise knowledge needed in emergency and critical care medicine. It's never just high blood pressure. It's always about where the pressure is high and what damage it's causing. And those answers guide completely different medical responses. It's a good reminder that sometimes what seems like one simple problem on the surface can have profoundly different things going on underneath.
Spot on. So, for your provocative thought today, just consider how the body's amazing network of blood vessels, from the huge aorta down to the tiniest capillary in the lungs, can respond so differently to what seems like a similar problem, high pressure. It leads to vastly different medical emergencies, demanding completely specialized treatment pathways. It makes you wonder what other seemingly simple medical terms might be hiding similarly complex and critical distinctions just beneath the surface. Perhaps something worth a deep dive of your own.